no, ci vorrebbe, dopo prenderemo un domani.
Dear all, good afternoon or perhaps good morning, and welcome to our webinars. Today we have the last webinars dedicated on human milk. The next series on parenteral nutrition will be held around the end of May. The lecturer today will be Professor Joseph Noy, Chairman of Hippocrates, and the title of his lecture is Human Donor Milk, Not a Panacea. Now I leave immediately the floor to the chairman of this morning, my friend Virgilio Carnelli, who will introduce Professor Neo. Please, Virgilio. You are muted. You are muted. Virgilio, you are muted. Virgilio, you are muted.
Thank you. Sorry. It's really give me a great pleasure, to welcome you to this third lecture of the first module of the nutrition series of the UMPS and Hippocrates Foundation. The first two lectures were really smashing, extremely interesting, and was a pleasure to listen. But now it's even better today, and it really makes me happy, give a pleasure to introduce Joe New. Joe, it's a world famous scientist, doctor and scientist. He graduated at the University of Wisconsin. He did the pediatric training at Johns Hopkins, and it is his fellowship at Stanford. And he became an associate in '84 in the University of Florida, Gainesville. And well, about that time, I guess I visited him, and it was a kind of middle morning. He was completely exhausted because he was the night on call, but he took the time and we had a nice chat. And I still remember, our brief conversation and his enthusiasm and his willingness to share his view. And it's one of my good memories. It was nearly 40 years ago. So it's been really a long time. Joe did additional training at University of Bern, where he expanded his knowledge on intestinal epithelium lactase, and his really field of interest is developmental gastroenterology and neonatal nutrition biochemistry. Lately, he became more interested in the intestinal microbiome because of immunity, and he's doing some fantastic work in trying understanding the microbiome of babies in relation to the risk of enterocolitis. He is involved in novel non-culture-based technique to assess the microbiome, and in addition is also into fetal microbiome and the effect on antibiotics on multiomics. So a lot of experience, a lot of knowledge, exciting nutrition, and today he will talk on human donor's milk, not a panacea. Please, Joe. Looking forward.
Thank you, Virgilio. real pleasure to be here. And let's see if I can get my screen up. Can you all see the slides okay? Okay, good.
Okay.
So I want to start with my disclosure slide. I have no conflicts of interest. And over the next 50 or so minutes, I want to give you a little background about human milk and talk a little bit about some of the evolutionary aspects of human milk, and then some of the critical components of human milk. Many of those have already been covered in Cammie's lecture and Ricardo's lecture. And then I'll talk about the intestinal mucosal immunity in milk, mother's own milk versus donor milk, some of the compositional advantages, and then how can we make donor milk more like baby's own mother's milk by some techniques. So let's start over here. This is a very famous scientist. His name is Richard Feynman. He's a quantum physicist who won the Nobel Prize. And not only is he very well known for his quantum physics and winning the Nobel Prize, he also has several interesting quotes. And here is one of them. We must be careful not to believe things simply because we want them to be true. No one can fool you as easily as you can fool yourself. Religion is a culture of faith. Science is a culture of doubt. And this holds true for human milk. Some of you may be familiar with this picture. Here we have a child who looks like he's about 8, 9 years old, who's still breastfeeding. And the cover here says, "Are you mom enough to breastfeed your child?" We have this concept that breastfeeding will lead to children who are absolutely brilliant, whereas if they're formula fed, they will grow up to be dunces. There's so much pressure placed on mothers that sometimes they are made to feel that they are second class if they are not able to provide breast milk for their babies. And in fact, there are some issues, and this is a cartoon that says you are completely free to carry out whatever research you want as long as you come to these conclusions. And here is a National Institutes of Health grants officer talking to a scientist. So these are some of the issues that I think we have to be somewhat concerned about. Rather than taking everything by faith, we have to think about what's really going on when we talk about human milk. Now let's backtrack a little bit and go back in terms of the evolution of lactation. And I want to go back 400 million years to the bottom of this slide, when animals first came out of the oceans and they started walking on 4 legs out of the oceans. And one of the things that happened during that time is that they started to lose some of the scales that they had as fish. And they started to develop some sweat glands. And the eggs that they started to lay were no longer the hard-shelled eggs. They were more like parchment. And some of these secretions actually began to cover these eggs and provide protection for these eggs, immune protection for these eggs. And as time went on, what happened is that these very primitive animals started to evolve into amphibians, and some evolved into the birds and the lizards and the dinosaurs. And as time went on, some of these early animals started to evolve into what are called the synapsids. And these are some of the earliest mammals that we know of. These, over time, started to develop more and more of these sweat glands and sebaceous glands. And about 201 million years ago, they began to evolve into protherians which means that they did not have a placenta, and therians, where they had a placenta. Now the protherians consist of animals that we now know of as the monotremes. These are the oldest taxon of the class Mammalia, and they lay eggs. They do not have a placenta or nipples. Then we have the marsupials. And here's an example of a marsupial. And here is a fairly well-developed baby in the pouch of this marsupial kangaroo. But this is a less well-developed marsupial that is feeding from the mother. And in marsupials, placentas are not very well developed. They have very short gestation, and they already have nipples. And then we have the eutherians, which have placentas. And here's some examples of eutherians. Here's a polar bear mother feeding two babies. And here are some human mothers feeding their babies. Okay, so we have the monotremes, marsupials, and eutherians. And of interest is that when you look at the monotremes, for example, here's a platypus. They do not have the nipples, but the female sweat milk from her belly from these sebaceous-like sweat glands. And the baby platypus drinks from these sweat glands. Of interest is the fact that this is a paper that was published a couple of years ago. Monotreme lactation protein is highly expressed in monotreme milk and provides antimicrobial protection. So this is something that is highly conserved from millions of years ago. And even more primitive than that, we have amphibians who have secretions, like frogs have secretions that are known to have antimicrobial properties. And we're beginning to think about these as potentially being used when we have resistance developing to our currently used antibiotics. So these primitive milks, these primitive secretions have these immune factors that we are beginning to recognize are highly conserved and were actually conserved in milk. Now, what about the composition of human milk? Why should we even care? Well, human milk is considered the gold standard, and it's favored by evolution, as well as numerous studies supporting better health. Some of the components of human milk are being viewed as protective or therapeutic agents, as well as agents that promote subsequent health and neurodevelopment. And industry is working very hard to try to copy some of the composition of human milk. Now, when we try to evaluate human breast milk composition, we have some general concepts that we have to think about. It's very different than what we find in the cow's milk or other mammalian milk-based formulas. It has a dynamic composition. It varies within a feeding over lactation and between mothers and populations. So if we want to evaluate breast milk composition, we have to think about several important concepts. If we study human milk composition, we need to sample it over 24 hours, longer periods of time. We have to collect it on multiple occasions over time, which is not that easy to do. We have to standardize at a specific time of the day. Avoid collection from a breast that was used for nursing within the past 2 to 3 hours. And record other conditions such as whether milk was pumped, freezing, thawing, duration of storage. The gold standards components of human milk are being viewed as prophylactic or therapeutic agents. So we have to be very careful in terms of how we analyze human milk if we want to consider mimicking human milk. And so this just tells us how complex this is and how difficult it is to try to mimic this. Now, here are 2 samples of human milk, and one does not need a principal component analysis to be able to look at these 2 milk samples and say they're really different from one another. So on the left, we have colostrum, and on the right, we have mature milk. Colostrum is produced in low quantities in the first couple of days after parturition. It's very rich in immunologic components: secretory IgA, lactoferrin, white blood cells, epidermal growth factor, and various other growth factors. Tight junction closure occurs in the mammary epithelium, and sodium to potassium ratio declines and lactose concentration increases once the colostrum begins to be altered over about 2 to 3 days and turn into this transitional, more mature milk. And the transitional milk after 2 to 3 days, we can tell that it is transitioning by looking at the sodium concentration, citrate, and lactose concentrations. Okay, and here we have a very low birth weight infant. This is an ELBW infant that we see a lot in our neonatal intensive care units. How do we go about nourishing a baby like this? Well, we usually start with parenteral nutrition. But when and how should we start with enteral feedings? Well, in the past, prior to about 10 to 15 years ago, it was very common to only provide parenteral nutrition for fairly long periods of time, week, 2 weeks, sometimes even 3 weeks, to these very low birth weight babies. But over time, we began to recognize that this is not the right thing to do. And one of the pioneers that actually taught us that how important enteral feeding is Dr. Elsie Widdowson from the UK. And over 60 years ago, she did work on suckled pigs. And she found that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. Several other studies were done in animals that looked at the growth of the intestine. And if you only provide parenteral nutrition to these animals without putting food into the gastrointestinal tract, the gut will not grow. This is something called the trophic effect of food. Work that was done at Baylor back over 20 years ago by Dr. Shulman and Chandler was very interesting in this regard. And at that time, it was very common to not enterally feed preterm babies for long periods of time. So this study was possible at that time. And here we see 2 groups of babies. These were all averaging about 1 kilogram at 28 weeks gestation. One group of babies received only TPN to day 15. The other group started to get some food into the gastrointestinal tract, small amounts, less than 20 milliliters per kilo, from day 4 to 14. And Chandler and Shulman did these permeability studies using something called the lactulose to mannitol ratio and evaluated these babies at 10 days. And here we see that those babies who received TPN only had a leakier gastrointestinal tract, more permeability than those babies who had some food in the gastrointestinal tract. This is very important because the leakiness of the gastrointestinal tract can cause translocation of various materials and cause an inflammatory response in the intestine. There are several other studies very important in this regard, and here's one study from Dr. Cami Martin's group, and this is the first author here was Dr. Konnikova, one of Dr. Martin's fellows at that time. And in this study, this was an observational retrospective study where they looked at early feeding versus late feeding. The early feeding was where they enterally fed the babies prior to 4 days, and the late feeding was after 4 days. And they looked at some of the adverse outcomes. And here we see these adverse outcomes, and we see in the late feedings a much greater incidence of adverse outcomes than in the early feedings. Well, this was an observational retrospective study, and even with correcting for some of the confounding factors, some of these findings were still present in the late-fed babies, some of these, this increase in these adverse outcomes. Of interest is that at 2 weeks after birth, inflammatory mediators were higher in those babies who received the late feedings versus the early feedings. But again, this was a retrospective observational study. But studies have been done that were prospective that began to look at this. And this is a study from the UK, the SIFT investigator group. And this was a trial of 2 incremental feeding rates in preterm infants. And in this study, they had a strategy of randomizing the babies to advancing milk feedings in daily increments of 30 milliliters per kilogram as compared with 18 milliliters per kilogram. And what they found was that there was no difference in necrotizing enterocolitis, late onset sepsis, or in adverse outcomes at 24 months of age. So this is something that makes us think more and more about the use of human milk and how we can best go about providing human milk to babies. Well, there's many mothers who cannot produce milk for their babies for various reasons. They may have to go back to work. They may just not be able to produce it for various reasons. And here's a study that was done by Hans van Gouderver and colleagues, actually a review looking at the donor milk history. And some of this actually started after World War II, where many countries started a human milk bank. And this was collected at home and brought to a central place, a blood bank or a hospital, and then vacuum dried. And in the 1990s, the HIV epidemic began to stimulate preterm formula use. But then also in the 1990s, Dr. Alan Lucas and Cole reported that in exclusively formula-fed babies, necrotizing enterocolitis was much higher than in those fed breast milk alone. And there were other numerous papers that reported an association with a lower incidence of nosocomial infections when own mother's milk was fed instead of preterm formula. And here is just some of the results from the very classic, famous Lucas and Cole study. So here we see formulas only, and this is necrotizing enterocolitis. And here we see human milk. So from the confirmed cases of necrotizing enterocolitis, we have a 7.2% baseline with formulas and 1.2% with human milk only. So a marked decrease in necrotizing enterocolitis with the use of human milk. And more recently, in the United States and also ESPGHAN and other societies have really began to try to push the use of human milk for preterm babies. And this is the 2012 American Academy of Pediatrics guidelines. And the underlined part here, I want to just read this to you. If mother's own milk is unavailable, despite significant lactation support, pasteurized donor milk should be used. Quality control of pasteurized donor milk is important and should be monitored. And this is for infants weighing less than 1.5 kilograms in neonatal intensive care units. So here's some questions that we need to address. Can these guidelines lead to harm? Is there a rationale to use mother's own milk versus donor milk? What components are lost with routine pasteurization for bank donor milk, and what is their importance? And how can we make donor milk more like baby's own mother's milk? So a couple of years ago, after the 2012 guidelines were introduced, Dr. Leslie Parker, who I work very closely with at the University of Florida, and her group did some work where they looked at pre-2012 and then shortly after 2012, a year or so after that, and then a couple of years after. And what they found was that over time, that the use of the baby's own mother's milk began to decline and donor milk use increased. So rather than actually using more of the baby's own mother's milk, we saw an increased use in donor milk. And this was also witnessed in several other neonatal intensive care units, not just in our neonatal intensive care unit at the University of Florida. Okay, here's a quiz. The average protein content of unfortified donor milk is A, the same as preterm baby's own mother's milk, B, adequate for optimal growth of the extremely low birth weight infant, C, approximately 2.2 grams per deciliter, or approximately 0.9 grams per deciliter. Well, the correct answer is the last one. If we look at the protein content of mother's milk over time, especially preterm baby's milk, mother's milk, we see fairly high protein content in the first week of lactation, but that begins to drop. And most donor milk is provided from mothers after they have been lactating for several months. And so the protein content is quite low. The fat and the carbohydrate content is not that terribly different, but the protein content is quite low in donor milk. So what is the protein requirement? Well, this is something that was done by Eckhart Ziegler several years ago. And he looked at the protein that the fetus was getting in utero and the requirement of protein that a preterm baby would have if that baby was delivered at various gestational ages. So the estimated protein requirement for the human fetus was about 3.5 to 4 grams per kilo per day. And if you take the amount of milk required to provide that, that baby would require about 330 milliliters per kilo per day of term donor milk to meet that requirement. That's a tremendous amount of volume, and most of our babies, most of our very preterm babies, cannot tolerate that volume. What about micronutrients, vitamins and minerals? Well, vitamin K is extremely low, and injection is needed to prevent hemorrhagic disease of the newborn. Vitamin D is also low in human milk, and supplementation is suggested. And the vitamins may vary in the diet of mothers, and multivitamins to the mothers is recommended. The iron concentration is also low, although it's more bioavailable, but it is relatively low in human milk. Calcium and phosphorus in human milk is also low. And here is a picture or x-ray, and what we see here is a broken bone in a baby. We unfortunately see this too often in our preterm babies. And this is due to several reasons. We use a lot of diuretics, we use steroids, but also the calcium and phosphorus that is required by these babies is very high. And if we look at the human milk quantity, it does not meet these requirements. So we need to fortify it. And if you look at preterm formulas, you see that that is similar to what is seen in fortified human milk and what is required. Now, studies have been done looking at formula versus donor breast milk for feeding preterms. And this is a study that was done, a meta-analysis that was done by Drs. Quigley, Embleton, and McGuire. And here they looked at several different studies in this meta-analysis, and they compared the formula milk use versus donor milk use, and they looked at weight gain. And what did they find? Here we see that it actually favored formula, that you had a better weight gain with formula than with donor human milk. What about linear growth? Also favored formula. What about head growth? Also favored formula. Necrotizing enterocolitis. Here it favored human milk. Now let's talk about this a little bit more. This is a study that was done by a Canadian group by Debbie O'Connor and colleagues, and reported in 2016 in JAMA. And if you look at the what they did here, they looked at the donor milk versus preterm formula, and they looked at cognitive outcome, which is the primary outcome, language and motor skills, and found no difference between preterm formula use and donor milk use. They did see some differences over here in terms of their secondary analyses. In terms of neuro impairment score less than 85, they actually saw an advantage of the preterm formula over donor milk. So I'd like to summarize some of the outcomes in this study as far as their primary outcome. Among very low birth weight infants, the use of supplemental donor milk compared with formula did not improve neurodevelopment at 18 months corrected age. If donor milk is used in settings with high provision of mother's milk, this outcome should not be considered as a treatment goal. As far as secondary outcomes, donor milk-fed babies compared to formula-fed babies show trends toward lower language and motor development. Donor milk-fed babies had higher cognitive neuroimpairment scores and a trend toward higher language neuroimpairment scores. However, fewer infants in the donor milk group had necrotizing enterocolitis stage 2 or greater. Now remember, this was a secondary analysis and looked at retrospectively. Now, what about necrotizing enterocolitis? Here are some pictures of a baby with necrotizing enterocolitis, distended abdomen, periumbilical erythema. This is the X-ray showing pneumatosis intestinalis, portal venous gas. This baby was taken to surgery, and you see this piece of necrotic intestine here that was taken out. And fortunately, this baby actually did fairly well. But should we be skeptical of some of these studies on human milk and necrotizing enterocolitis? Well, I think that we need to be very careful, because we are beginning to recognize more and more that what we are calling necrotizing enterocolitis is probably more than one disease. It's something like diabetes. We have type 1 diabetes and we have type 2 diabetes. We have different forms of cancer. Well, we have different forms of intestinal injury, and they are not all necrotizing enterocolitis. So here are some of the different forms of intestinal injury that we are calling necrotizing enterocolitis. And some of our databases are just filled with garbage in terms of what we are calling necrotizing enterocolitis. So we have to be very careful, because there are these imposters. In terms of studies where NEC is being looked at, studies where NEC is adjudicated, it should be adjudicated by, if it's not adjudicated by non-biased observers, this can lead to different results than when diagnosed by a clinical team or radiologist asked to rule out NEC on an abdominal radiograph. We have a question on whether medical NEC, as currently most commonly diagnosed, is this potentially feeding intolerance or food protein intolerance syndrome, or one of the other imposters. So we have to be very careful by what we are calling NEC. Okay. Now, let's get to some of the components that make human milk special by interacting with the intestine at the mucosal immune system interface. And many of these have already been discussed by Cami Martin and by Ricardo. And I'm not going to get into all of the details of these, but I'll talk about a couple of them. Now, one of the important factors to remember is that donor milk in most countries of the world, bank donor milk is subjected to a pasteurization process or some kind of treatment, mainly to get rid of some of the pathogens. Well, Holder pasteurization is 62.5 degrees centigrade for about 1/2 hour. And this is a slide courtesy of Peter Hartman from Perth, Australia, that shows what happens to some of the milk components after this pasteurization process. Here we see some of the enzymes: alkaline phosphatase, bile salt stimulated lipase, almost completely wiped out. We see some of the immunoglobulins decreased. We see several alterations because of this pasteurization process. So before we get into some of these different components, I want to just show you this slide and ask you, what are we seeing here? If you look at the bottom, you see the legend, which is IgM, IgA, and IgG. And in different mammalian species, such as the pig, cow, horse, and sheep, we see primarily IgA present as the dominant immunoglobulin of human milk. IgG is present as the dominant immunoglobulin, whereas in the human, we see IgA as the dominant immunoglobulin. Well, why is this important? Well, we have production of IgA by plasma cells, and this is the subepithelium, and these IgAs are produced, and then they are dimerized and a secretory component is added, and then in the lumen of the intestine, this is very important in containment of certain kinds of microbial components. And here we see a baby that is being protected against necrotizing enterocolitis with the IgA. Here we see enterobacteria coming out of the stools of babies connected to the IgA component. And this is thought to be a very important protective component of human milk. And here's some recent data from our own laboratory. We've been looking at the vaccines, similar to what Hans talked about a couple of days ago. And here we see the SARS-CoV-2 specific IgA in breast milk. And this is after either the Moderna vaccine or the Pfizer vaccine. And we see pre-vaccination concentration. This is 14 to 30 days post the first dose, and we see an increase, and then a very large increase in the IgA in the breast milk after the second dose. Now let's get back to what the abolishing some of the enzymes and some of the components of human milk using the pasteurization technique. Here we have the BSSL, or the bile salt stimulated lipase. And here we see this is bile salt stimulated lipase, which is present in the milk itself. And it is inactive initially, but it's stimulated by the bile acids that are produced in the upper gastrointestinal tract. And with this stimulation, you have the breakdown of triglycerides into monoglyceride and free fatty acids. In preterms, we begin with lower pancreatic lipases. And if we have the abolishment of this, then of this bile salt stimulated lipase with the pasteurization process, then you could very likely consider that the efficiency of the fat digestion is not going to be as good as if you have it present. And this is a study that was done a few years ago, and you see a couple of authors here, very familiar to us, Virgilio and a couple of other people, Alexander Lapillon, who did some work looking at the recombinant BSSL and showing that this actually can improve growth and absorption in preterm infants fed formula or pasteurized breast milk. What about this other enzyme that we talked about before, alkaline phosphatase? Intestinal alkaline phosphatase dephosphorylates various pro-inflammatory microbial components, including LPS, and thus making them unrecognizable by toll-like receptors. And this can directly inhibit the nuclear factor kappa B pathway components. So then what happens is that with alkaline phosphatase present, you will immobilize some of the potential pro-inflammatory effect of lipopolysaccharide. Well, if you get rid of this alkaline phosphatase in the milk, at least theoretically, you will have a greater inflammatory response in the intestinal tract. Here is some work that was done in mice and experimental sepsis. Here we have one group that received LPS and recombinant alkaline phosphatase, and here's LPS in the control fraction. And this is looking at body temperature over time. And you can see that the body temperature decreases over time in the those animals who were the controls after getting LPS. But here's the animals who got the recombinant alkaline phosphatase. And here's the survival. Those with the recombinant alkaline phosphatase survived much better than those without within this experimental sepsis model. Now, what about the microbiome? Why do we have all this fuss about the microbiome? Well, we have numerous books that have been written about the microbiome. And over the past several years, we now have over 86,000 publications cited in PubMed related to the microbiome. Why do we have all this fuss? Well, when it comes to human milk, here's a classic study that was published in PLOS One in 2011 from Hunt and colleagues. And in this study, they looked at milk from 16 mothers. And each one of these S's represents a different mother. And here we have in these bar graphs, 1 week, 2 weeks, and 4 weeks after birth. And the different colors represent different taxa of bacteria using 16S sequencing. And here we see that in this one mother over time, the bacteria look very similar. But when we compare this mother to the other mothers, and when we look at all these different mothers, the bacteria are very different, even though over time they seem to be somewhat similar. But one mother has very different bacteria than the other mothers. So this suggests a personalization of the types of microbes in the baby's own mother's milk. There are a lot of microbes in human milk. This is a study that looked at the quantity of microbes, and here's colostrum, here's transitional, here's mature milk, and we see about 10 to the 5th microbes per milliliter. And these are just the different mothers, and you can see the variation, quite a bit of variation, but again, the median is a fairly high number of microbes. So if we extrapolate this and assume an intake of milk, of human milk, of 800 milliliters per day, which is something that we might consider is very common in a term baby who is fully breastfeeding. And if we assume 10 to the 5th to 10 to the 6th bacterial cells per milliliter, this will provide 10 to the 7th to 10 to the 8th bacterial cells, which may be personalized daily, close to the dose used in most probiotic studies. So when we give human milk, we are actually giving microbes that can be probiotic. And in addition to the microbes in the milk, in the human milk, you also have the prebiotics, but that's another whole, at least a couple of lectures in itself. Now again, this is personalized milk, but it's also dynamic. And if the baby has contact with the mother, this is very important. Work that was done in the late 1970s by Drs. Kleiman and Alan Walker looking at animals suggested that there was this system called the enteromammary immune system. And the way this works is that you have the mother and the baby in close contact with one another. The baby may have been exposed to certain microbes, and the baby's immune system may still be undeveloped, but the mother's immune system is quite well developed. And when the mother obtains some of the microbes from the baby, she has an immune response to these microbes, and these immune factors get passed on to the baby through the breast. Well, in the 1970s, this was looked at more in terms of animal studies, but more recently, we're beginning to recognize more and more, and also with some of the COVID studies that are being done, is that this enteromammary system really is very important. And here's one study that was done in Israel, where they looked at 12 infants with viral disease versus controls. They took milk samples 7 days apart while the infants were recovering from the illness. And they saw that in those babies and the mothers who were recovering from their viral illness, there was an alteration of the CD45 leukocyte count, the macrophage count, and the TNF alpha. So there was a dynamic change going on in the milk of the babies as they were recovering. And this dynamic change did not occur in the control babies. And this supported the dynamic nature of the immune defense in breastfeeding infants. We also know that the metabolites in milk are different in different geographic regions. And Cami talked about the metabolome yesterday. Here we see in China, in Finland, in South Africa, in these different regions with a principal, when you do a principal component analysis, the metabolites are different. And this may reflect the diets in these different regions of the world and how they cause a difference in the metabolites in the milk. Now we have some caveats. Simply providing pump mother's milk is very different than breastfeeding. We have a question of whether baby's own mother's milk pumping and freezing and lack of direct maternal infant contact ameliorates some of the beneficial effects of breastfeeding. And can we personalize donor milk? Well, let's talk about this last factor, personalization of human milk. Well, it's very well known that donor milk is pasteurized and that you lose many of these components. But if you have a mother who is able to produce small quantities, and if you take some of the small quantities of the baby's own mother's milk and add it to the donor milk, you can begin to reconstitute some of the microbes. And work that was done by Nicole Cacho in our group and Graziella Lorca looked at this. And we published this in 2017 in Frontiers in Microbiology, and found that with 10% dilution of donor milk with baby's own mother's milk, and with letting this sit for about 4 to 8 hours, we could get a microbial reconstitution by both culture and non-culture based techniques that look very much like the baby's own mother's milk. And we also did some studies looking at the metabolome, and we found that with this reconstitution, this is the baby's own mother's milk, this is the donor milk, and with the reconstitution, we can start to get the milk looking much more like the baby's own mother's milk in terms of the metabolomic profile. We also, and Hans van Goudever mentioned this a couple of days ago, are beginning to develop techniques that may be better than the Holder pasteurization. Here's an example of one of these techniques. This is ultraviolet irradiation, and Hans also mentioned pressure-based techniques, and some of these may actually be much better than the Holder pasteurization technique in terms of maintenance of some of the proteins in the baby's own mother's milk. But again, the dynamic nature is one that's going to be very hard to reproduce. So, in summary, is donor milk a panacea? No. Many of the active components, including live microbial components, cells, and enzymes that may provide benefits are lost in the processing of donor milk. Transplantation techniques, stimulation of early lactation, and improvement of processing techniques may be useful in increasing baby's own mother's milk use, or at least making donor milk more like the original. The mother provides personalization and precision. And the question is, can we ever mimic this? I think it's going to take a lot of research and a long time to be able to mimic that. Thank you for your attention, and I'd like to acknowledge a lot of the people and groups I have worked with over the years. Thank you very much.
Thank you, Joe. Very comprehensive, very thoughtful. Thank you again. I would encourage people to come up with questions. And of course, we do have questions, and some questions bring us to some simple and interesting sort of points that we face in our daily work in the neonatal intensive care unit. There is a question, Joe, that asks early feeding. What, if you comment on expand what is early, and this this colleague asked 12 hours is early enough or even earlier than 12 hours. That's then perhaps there's another questions that you could address together. And then are we behaving differently? Do we have different thoughts on how we feed SGA and AGA baby in terms of early feeding, I assume? You want to start with this answer, and then I...
Well, let me start with, if we just think about term babies, a term breastfed baby in the first 24 hours gets about 30 milliliters of milk, okay? So really is not getting that terribly much milk. And for us to try to give large quantities of milk in the first 24 hours to a preterm baby is probably not necessary. But I think that it is important to provide at least a little bit of milk, preferably colostrum, if that's at all possible, to the preterm baby as early as possible. But we don't need to push to get full enteral feedings within the first couple of days after birth. I think that many of our neonatal ICUs are now able to, using some of the techniques that I mentioned before in the New England Journal paper, we are able to get many of our babies to full enteral feedings within 5 to 7 days after birth. So that it is possible to provide early feeding. I think the technique of priming or minimal enteral feeding, where you are giving less than 20 milliliters per kilogram per day, which is something that I strongly recommended prior to about 10 years ago, it's no longer necessary to do that. I think that the studies from UK and various other places have been showing that we can provide enteral feedings at and go up at a faster rate than we have in the past, safely. So I think that that was trying to answer one of the questions. Virgilio, what else was there?
There is another question, but you already answered about relactation and so. But there is a question by Nick. Nick is asking, well, he says you have less neck and you pay a bit the price in slower growth. So what is the balance, and what do you do in your own ICU?
Okay, so one of the things that I try to get across in my lecture is that, you know, what is necrotizing enterocolitis. And I think that we make a lot of mistakes in terms of the diagnosis of necrotizing enterocolitis. So if we have a baby who is having some feeding intolerance, one of the first things we do is we get an X-ray on the baby, and on the X-ray request to the radiologist, we say, please rule out necrotizing enterocolitis. And the radiologist will look at that very carefully and say, I cannot rule out necrotizing enterocolitis. There's an area that's a little bit fuzzy on this radiograph. And what the clinicians do then is write in the chart, necrotizing enterocolitis, stage 2. And that baby gets placed on antibiotics, and it has 7 days NPO. So I think we need to be very careful with our diagnosis of necrotizing enterocolitis. I am pretty convinced that many of the babies that we are diagnosing as having necrotizing enterocolitis have merely feeding intolerance and don't really have a disease per se. So let me give that to you as an answer, Nick.
Okay. I'll try to sort of summarize some of the, they're still concerned about SGA baby, and there's another question, what about 24, 25 weeker SGA babies? And would you, I assume they ask what you do in this type of baby, whether you have any concern with early enteral feeding in these tiny babies. And then there is another question on oral colostrum. I guess they want to know, the question they ask, what is the oral colostrum according to your experience, or what do you recommend about that?
So the SGA babies, there's many different reasons to be SGA. There are some of these SGA babies, IOGR babies, who have a history of reverse diastolic flow. I do worry about those babies, but I do feed them and I watch them very closely. But I do not hold back on their feedings unless they are showing signs of intolerance.
If I may add, in Ancona, we start oral feeding at 1 hour live, nearly in all baby, unless there are some catastrophic situation or situation that prevents of that. So, and our NEC rate is rather low, and we are kind of comfortable with we don't give probably a very large amount. We start with a few milliliters, but we find that starting 1 hour life is kind of safe, even in the tiniest and SGA baby as well. So
your other question about the oral colostrum is one. I think that some of the studies that we have are mixed, but I see no harm in doing this. I think that if anything, there is a very likely benefit, and we have been using oral colostrum fairly extensively in our neonatal ICU whenever it's available. And I like the idea of using the oral colostrum, but as far as the evidence base, I think that if you look at many of the studies, they seem to be mixed in terms of the results.
I think we can take 2 more questions. One question is sort of is asking whether we should pasteurize human milk at all, and it sort of states or so, and it's true, matter of fact, that in some country pasteurization is not widely applied to preterm human milk, and I guess there are sort of interesting in sort of in your opinion about what would happen if we were not to pasteurize donor's milk, preterm donor's milk, and so on. This is a question. And there is an interesting question as well on bovine-based fortifier, whether you see some concern or some dangers with bovine-derived fortifiers.
Sure. My understanding is that there are some places in Scandinavia and in Japan where they do not pasteurize the donor milk. And I think that if they have very careful techniques in screening the mothers, I think it's possible to do that. I still have some concern because if you have large quantities of donors and you mix it all together, that's a potential problem. If you have a situation where you have individual mothers, and I saw this in a couple of the neonatal ICUs in Spain, where they used milk from individual mothers and then analyzed it and gave it to individual babies to try to personalize. I really like that idea, but that's a lot of effort and a lot of work. And but I do like that technique. So I don't have a really good answer about the lack of pasteurization, or we should be pasteurizing it at all. But I think it is possible.
We have an observation concerning the fetus and the large volume of fluids, amniotic fluids, that the fetus swallow. And there is sort of a question, I guess they want to know your opinion about whether the baby would be able, or it would be indicated to give larger amounts or more diluted milk right after birth, as the fetus is used to swallow large amount of amniotic fluids. Is there any information on that? Can you comment on that?
So that has been thought about, but I think that in terms of giving large volumes, again, the postnatal situation is very different than the prenatal situation. And I think that giving those large volumes may be potentially detrimental, but it has not been tried to my knowledge to give those kind of same volumes as the baby would be swallowing in utero. But again, it's a very different physiologic situation postnatally than it is prenatally.
You have a lot of compliments from many people in the audience and a lot of questions, so it's difficult for me to pick up the most interesting one. I guess there is an interesting question concerning the stooling pattern. Is the stooling pattern affecting your decision on tolerance, on progression? Is something, so you put in the equation when you decide on how to feed a preterm baby?
Very little. I think that if a baby has not stooled in 5 or 6 days and has a distended abdomen, I think that that's a different story. But if the baby has 1 stool a day versus 6, 7 stools a day, and is doing well otherwise, the stooling pattern doesn't bother me. We do not give, and I actually recommend against doing routine stimulation, giving glycerin suppositories to babies routinely to make them stool.
There are 2 or 3 questions concerning how you could support colostrum expression, or to help the mother, to what organizational aspects you would promote to help the mother to obtain colostrum and to give colostrum to their baby. How is your unit organized in this respect, I guess?
So this is something that we are working on. I know Dr. Leslie Parker and several of our other colleagues are working on this, and this is something many neonatal ICUs across the world are looking at. And I think that this is really one of our most important concerns here, is how to stimulate the mother to produce her own milk. I think that one of the things that can be done is to consider the C-section rate in your neonatal intensive care unit. There are places in the world where C-sections are being done almost routinely. where you see them in private hospitals, almost 100% of the babies are being born by cesarean section. That slows down the breastfeeding process. I think that certainly C-sections are important in certain situations, but they should not be done routinely as are done in so many different places. That really can thwart the breastfeeding process.
Yes.
The stress that certain mothers have, if they have to know that they have to get back to work. I think that certain countries seem to know how to do it right with supporting mothers and families. Certain countries don't necessarily do it quite the way as well as other countries do. So we need to be able to support mothers and families so that they are not as highly stressed. This is very important.
There is also a question concerning CMV positive mother, IgG positive CMV mothers, and the question whether you are happy with 3 days freezing or you would go for post-sterilization. What is your local practice?
I don't think that freezing necessarily has that much of an effect on the IgG. I'm sorry, on the cytomegalovirus. It may have some effect, but I don't think that it automatically gets rid of it. So I think that babies can still, if the mother has IgG, has CMV in her milk, freezing will not necessarily get rid of it.
Yeah, there are data, I mean, not entirely, and that's why people are a bit nervous about that. Although there seems to be laboratory data that shows that 3 days freezing decreased the viral load by 95%, 96%. So you still left with a question whether, like 5% left of the viral load is still potentially harming the baby also. So it's, yeah, we in Ancona, I'm very much in favor myself, just to, I'm happy with 3 days freezing, but of course you cannot guarantee, I mean, the total safety of it. And so it depends how defensive you want to be. I think it's it's an open question. I guess we went through, there are several brilliant, thank you, congratulations. And I'd like to also to close this discussion, to thank you again. And it's wonderful. It was a wonderful talk. And I would like to remind you that we will have module 2. And that is entitled, What's New in Parental Nutrition for the Newborn Infants? And I hope to see you numerous sometimes in May this year, and you will update it with the exact dates. I'd like to remind you also that all these lectures are available at the websites of the UMPS and the Hippocrates Foundation. Thank you for being here, and thank you for our speaker, Joe New. Thank you, Joe. Fantastic.
Thank you.
Thank you all.